It's a beast of a disease. It's a beast of a virus, and the spike protein, what it can do to our bodies is not like anything we've seen with any previous virus. We are seeing a tsunami of neurodegenerative diseases like we've never seen before. And it is aging us at an accelerated rate, and nobody is talking about it or looking at it or trying to be proactive about it.
So how do you define long COVID?
I believe, Jason, that we have it all wrong based on what we really know now through the research and the literature that's been coming out over the last 4 to 5 years, that it's not not necessarily this constellation of symptoms that, can be over 200 plus different symptoms that can obviously present differently in different people. And people can have a conglomeration of different amounts of these symptoms. Maybe someone has one or two, maybe someone has like 20 or 30 different symptoms, right? But now we understand, based on understanding what's going on at a cellular level post vaccine or post exposure to the virus, that we can be seeing biochemical abnormalities that may precede clinical onset of certain conditions or problems. And so maybe we can catch some people after they've been exposed to the virus from going on to maybe manifest any of these number of conditions that, we'll get into. So I believe the spike protein and or the virus that we know now can be in our body for months, if not years, post-exposure, are driving at a cellular level conditions and problems that a lot of us don't understand in the community, and that we need to start recognizing, and it needs to start becoming part of the differential diagnosis, so that we're not just dealing with the crisis when it happens, but we're averting it altogether.
So I think that's an important thing to note. You're not necessarily experiencing symptoms. And you mentioned the spike protein. So if one were to do lab work and test for the spike protein, is there a certain number that you look for, and then a duration in terms of how long that number needs to sit in your system to be defined as having long COVID?
The problem is the testing is only looking at antibodies. Antibody testing is an indirect measure of trying to understand if you have circulating spike protein or persistent virus in the body. So if you have really high antibodies, so for example, Quest, their cutoff, it's a semi-quant, is greater than 2,500. And the spike antibody, the spike IgG antibody, that's over 2,500 from Quest and over 25,000 from LabCorp. So if you want an even better determinant of how many antibodies you have, it's LabCorp is actually more accurate. They can go a lot higher. So when I do a Quest patient and I see greater than 2,500, I don't know if they're at 50,000, 20,000, 10,000, So when you do the LabCorp, it gives me a more accurate depiction if I can catch them within that 2,500 to 25,000 range. And that is from exposure to the virus or the vaccine, because the vaccine was developed by using the spike protein as the antigen, right? But if you have exposure to the virus, the wild type virus, then you can also make an antibody to what's called the N protein, and like Nancy, the nucleocapsid of the virus. And that's what also distinguishes whether you've had recent infection or not. So for example, if I get a patient that tells me from the history, no, I haven't, I have only had vaccines, I haven't had the virus in a really long time, or maybe I had the virus 2 or 3 years ago, and I see that their antibody level is still super high, like over 2,500 in the 10,000 range, the 9,000 range, but their nucleocapsid is negative, then I can probably, with confidence, realize that, yeah, this isn't from recent infection. You probably have circulating spike protein that's causing you to mount an antibody response over and over again. Because what's supposed to happen is after you're exposed to the virus or after you're exposed to the vaccine, in a normal immune response, that antibody response wanes. That's the whole reason why they recommend the vaccine every 6 months. Because if you had a sustained antibody response, you wouldn't need to keep getting a vaccine, correct? or if you had a sustained antibody response from the virus. But that N protein that comes from the virus and the spike protein that comes from the virus or the vaccine, those antibodies wane. You usually within 6 months, they keep coming down, down, down. So that's an exaggerated or an dysregulated immune response to have elevated antibodies for that long, or to have a nucleocapsid, an N protein that's positive for that long.
And so is there a number? Do you want to see a decrease in that number?
Yeah, some people are like, "Oh, it's great that I have antibodies." I'm like, "No, it's not. Those antibodies are not doing anything for you."
How would you define long COVID? Like, eventually, like, is it anything greater than 0 or greater than 2,500?
No, okay, it's really hard because I don't use that. I use it as a guide to help me understand, but in the context of getting all these other biomarkers back. Does that make sense? Because the other biomarkers, the other advanced biomarkers that we're doing, that the vast majority of practicing physicians have never even heard of. Like when my patients take them to they're like, they have no idea. They've never even seen what this is. That are also offered by Quest and LabCorp, by the way. But they're very obscure biomarkers that, if, unfortunately, we don't really learn about in medical, or maybe we learned about it in medical school years and years ago, but we don't, they're not part of our everyday practice and things that we're looking at. But we know to look at them now because we know that post-COVID and post-vaccine, a lot of these things become dysregulated, and we have a dysregulated immune response, and some people are expressing this at a biochemical and or clinical level.
And what are some of those biomarkers?
Well, we look at, your ANA, which is your anti-nuclear antibody, because the spike protein causes something called molecular mimicry. So many of the self proteins in our body are self antigens that we recognize as self, the spike protein mimics. And then as a result, we start having a dysregulated immune response and start making antibodies to things that we normally see as self that are now not, right? So that's problematic. And if you check ANAs now, the vast majority of the population has positive ANA. Prior to the pandemic, I was a practicing gastroenterologist, and I would do ANAs and I would check blood work on hundreds, if not thousands, of patients a year. And I can count on one hand the amount of times I'd have a positive ANA. ANAs were not something that were pervasive throughout the community. I check ANAs on people all the time now, and they have either, like maybe not high titers, but 1 in 40, 1 in 80, 1 in 160. And I guarantee you, and when I do a full autoimmune workup on them, nothing else is turning positive. And it's because it's like these undefined self antigens that are becoming positive and causing, the ANA to go positive. And so that's one marker we look at. We look at another one called human transforming growth factor beta 1, which is a multifunctional cytokine that impacts our body's ability, from everything from inflammation to regulate inflammation, tissue repair, immune modulation, things like that. And prior to the pandemic, also TGF beta 1 was probably utilized most by functional neurologists, also doctors that do a lot around mold toxicity. The TGF beta 1 will go high because the MMP, the matrix metalloproteinases, go up. That drives TGF beta 1. So we see these elevated, and especially if you had like an elderly patient that was, you were concerned about Alzheimer's, you would do this, the TGF beta 1 would be high. And then we noticed that in these patients that were presenting with post-COVID conditions, or exposure to the spike protein, post-spike protein exposure, that their TGF beta 1s were sky high. Like, I mean, the range was 300 to 2,200, and we were seeing people on average 8,000, 10,000, 15,000, over 20,000. And we still do to this day. And then the lab companies, unbeknownst to us, changed the reference range in the last year. LabCorp did it like 2 years ago, and then Quest coming up in December will be a year ago. And all of a sudden, it wasn't highlighting or lighting up, and the new reference range was 2,200 to 22,000. So this was normalized in the population. They were like, whoa, why is, because everyone was walking around with super duper high TGF beta 1s. But that's a huge problem, right? And so if you have people now walking around with these elevated levels of TGF beta 1, it drives fibrosis. Like cardiovascular inflammation, neuroinflammation, fibrosis. It's a dangerous cytokine to have elevated permanently or persistently. And so that's something we look at, that we see. We see D dimer. We check a D dimer on most people that are just coming through our door, even our longevity patients. We check an A beta 42/40 ratio on the vast majority of our patients coming through, because the spike protein is driving beta amyloid production. And then, I would say from a screening standpoint, that I'm checking most of, and I'm doing the nucleocapsid protein and the spike IgG. And then if I see some of those things elevated, then I do an even deeper dive, right? Because I look at through the lens of systems biology when I'm like working up any of my patients, whether it's for chronic disease or longevity. And then I'm going to do a whole bunch of other biomarkers, right? That are related to autoimmune disease, that are related to your immune system, like your cytokine panels, looking at, T lymphocytes, B lymphocytes, CD4 counts, looking at thrombosis panels. These are severely abnormal in a lot of people just walking around in the population right now.
And I'm gonna get to the why behind this, 'cause and I wanna double click on this notion that you don't necessarily have to have symptoms to experience long COVID. And so I'll share personally why I'm fascinated by this. So,
And I can explain why that is after you're done.
sure. So I'm doing my regular lab work with Frank Lippman, and he layers on the p-tau test, which is what everyone is, not everyone, but a lot of people are talking about, because it's inflammation in the brain that is likely associated with early onset, not early onset, more like an increased likelihood of potentially having dementia or Alzheimer's. And so I'll paint the picture. It's first week of July. I'm in Aspen with my two little girls. We're on family vacation. I wake up and I've got the Quest app. And so I get a ping. I look and I get a result. And my two p-tau numbers are like sky high in the red. And I know what they mean. And I'm just like, oh my God, like this can't be true. I am
So he did a p-tau 217 and a 181 on you.
correct.
And just so you know, for the audience, I did and especially the 217, when that's elevated, that's highly sensitive and specific. It's validated. We've studied that. Like that's a very important biomarker right now.
Correct. And so I'm thinking to myself, this can't be true. I am so metabolically fit, like in terms of lifestyle. I don't check like I'm active, like physically, mentally, I feel great. I don't have a genetic history. I've got one copy of the ApoE34. Like it doesn't run in my family. I'm like, I'm like, what is going on here? And then, so I'm kind of like freaking out, but then I have to like focus to like my children. And then I get my COVID result, and my SARS CoV-2 spike antibodies is north of the upper limit at 2,500.
And let me ask you a question. Let me stop you, so we can let the audience put this into context. When was the last time you had a vaccine or the virus, to your knowledge?
So I had the vaccine in early 21, but I'm convinced, according to my Whoop data and Aura data and how I felt, that I had COVID probably 30 days prior, end of May. And I did the labs end of June.
And then I'm assuming, I know Frank, he must have checked the N protein, the nucleocapsid. That was probably positive too, but we should go back and look.
So was this the NFL or no?
No, the nucleocapsid antibody. That's the second part of the COVID antibody testing.
I didn't have it.
Then then there's no way.
So it's well, we'll get back to me.
That's a whole other discussion.
So at any rate, Frank says, I think you have long COVID. And I say, I feel great. And he says, it doesn't matter. You'd be surprised how many people are walking around with similar p-tau numbers that are elevated and coming back for COVID and they don't know it. And he said, you need to talk to Robin. And it's the deeper question of, okay, if I have long COVID and I feel fine, why does it matter? Well, here it does matter, because The p-tau can be transitory, as which you don't want as like a reaction post immune stress, but it could also just hang out there for a while. So and what you don't want. And it can also lead to a bunch of other issues with cardiovascular panels and so forth.
Correct. That's just smoldering and that you're not having symptoms from. So I'm so glad we're talking about this, Jason, because you seem like a biohacker type of guy.
So I'm not a bi I'm just,
Okay, not that. I hate okay, but you're very into wellness, being fit, being proactive, right?
curious.
Yeah, and, you have all these guys out in the world, the Peter Attias and nobody's talking about this, and how sad is that, right?
No, it's yeah.
No, 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 because the spike protein is a true age accelerant. So we have all these people talking about anti-aging, they're in the anti-aging space, longevity, longevity, longevity. This has to be a major part of the conversation moving forward because what it's doing to us, it is aging us at an accelerated rate and nobody is talking about it or looking at it or trying to be proactive about it because, why.
What I don't want is this to blow up in a way. So we did some follow-up labs. So we tested the AB4240, which is the amyloid plaque, which you don't want, and I'm good there. We tested my NFL. I'm good there. We tested my HSCRP. I'm good there. We tested my MPO. I'm good there. So like those labs, if they came up as red, it'd be like, oh wait, like we really got to throw everything we have at this dementia and Alzheimer's risk. So I feel good about that. However, with that said, I don't want this COVID spike hanging out, elevating p-tau, because at some point you just don't want elevated p-tau forever. Because even if I don't have the dementia Alzheimer's, it's going to lead to other things.
That doesn't matter, right?
Exactly.
Look at it. Like we see every day, we see the sickest of this. We're like, ground zero here at my clinic. So people are flying in from all over the country for us to work them up, diagnose them, and then intervene. And I will say that we are seeing neurodegenerative diseases like we are seeing a tsunami of neurodegenerative diseases like we've never seen before. And I some of my dearest friends are functional, like one of my dearest friends who taught me so much over the last 5 years because I've had to become a mini neurologist in, you know, in the wake of all this happening. Um, she her clinic exploded even near the beginning of COVID. And now the amount of consults she gets on a monthly, yearly basis have like tripled or quadrupled. The amount of ALS she sees has skyrocketed post pandemic compared to prior to the pandemic. And what we're seeing too, which is super interesting, is a mishmash of neurodegenerative disease. It's almost like you can't, like, and I know in the conventional space, it's so important to have a diagnosis, right? You want to put that person in that category so that they can be in that box and you can treat them, right? So you want to have the ALS diagnosis, you want to have the Alzheimer's diagnosis, you want to have the Parkinson's diagnosis, but it's not. It's become a spectrum because of this massive onslaught of inflammation to the brain. And because the spike protein causes the formation of all these different neurotoxic fibrils, alpha synuclein, beta amyloid, CD130, like all the things that have to do with the different neurodegenerative p-tau. It's almost like a mishmash of disease. And so, so it's very hard to treat. But again, if you go to root cause, and have an understanding of the pathophysiology driving the problem, you can help a lot of these patients earlier than later.
And like my PSA, the reason why I'm doing this is, look, I don't want to freak everyone out, but I do think if we back up and look at the numbers, I think it's pretty safe to say that probably 95% of the population has either had COVID at one point or been vaccinated. And then within that subset, there are a lot of people, maybe genetic or lifestyle, like have trouble clearing it, myself included. And so I just want people to be aware, because I'm sure that there are folks like me who feel totally fine, have no symptoms, or feel amazing, but there's something brewing inside them, and you want to get a hold of it early before it gets to a point, not necessarily of no return, or it just becomes a lot more difficult it becomes something else. It takes the form of maybe possibly a neurodegenerative disease, which is a lot harder to throw something out if it's too late. And so, with that said, we've got, I'm operating under the assumption that a lot of people probably have a spike in them and they're maybe unaware. Then the question becomes, I know it's complex, but how do we rid ourselves? How do we detox ourselves in a way that doesn't necessarily, I have a friend who like flew to Switzerland and, you know, handles it there with the latest and greatest.
So got probably ionosphoresis or plasma exchange. Yeah.
So how do we, like, what are the things we can do, whether it's uh choline or like just more general from like a lifestyle, to start throwing, like, one, getting an understanding, like I think we've gone through the things you should test for, because I also don't want, I want people to be aware, I don't want them freaking out. And then what are the things we could do, whether like I have COVID today, I want to make sure this doesn't balloon or COVID's floating around my system.
Well, okay, before I get to that, I just want to bring up two points that are really important. The first is I just want to highlight the evidence around why this is happening. So there have been like at least 3 or more papers in the last year and a half alone that have been put out by major, respected peer-reviewed journals talking about what's happening at a neuro level. And the studies show and prove what we're talking about. This is why I just want to explain this. So when you look at even young patients, like in their late teens, early 20s, that have had either an asymptomatic infection or just a mild infection from after one COVID infection, they have brain changes on imaging. They have lost their gray matter, white matter, and they have decreased cerebral blood flow to the brain. Okay. This has been published not just once, twice, 3 times, if not more. Okay. And there have been lots of postmortem studies published at this point that show the spike protein in the brain and like where it sits and what it does to the astrocytes. So this is all happening at a cellular level. So it's smoldering, but the proof is there. And that's why you're saying, why do I not have to have symptoms? These people didn't even know they had it. And they have changes in their brain, in the blood flow to their brain. They have less gray matter. They have less this is like significant. And this is just from one exposure. So that's the first thing I want to say. So there is proof out there. There are tons of studies that now validate what I'm saying. And this is why it needs to be taken a little bit more seriously. And we need to start maybe screening for some of these things, right? To be proactive. So that's the first thing. The second thing is it's really hard, right? We don't have an assay out there that's commercially available that measures the spike protein directly. Okay. So I do a lot of research with a group in Italy that has that scientifically validated, and they're the only ones that hold a patent that can use mass spectrometry to detect spike protein. And spike protein, we can differentiate spike protein from the virus versus the vaccine. And we can see if people are a hybrid, meaning they have both still circulating in their system for years, for months, if not years. We can see how it's impacting the gut. And just as a side too, not to complicate things, but the virus, and the vast majority of the medical community do not know this, aside from the masses in the population, that the virus behaves like a bacteriophage. This has been well documented and published by Carlo Brogna and Simone Cristone, who I do a lot of my research with. They've written dozens of papers already on long COVID and showing what's going on with the bacteriophage behavior. But the virus basically takes up residence in the bacteria in the gut microbiome. Once you do that, if you look under an electron microscope, you can see the bacteria teeming with thousands, hundreds, if not thousands of virions. And as a result, you have a massive onslaught to the gut because you've loss of all your important good bacteria, plus the metabolites that those bacteria make. That's impacting you as well. So it's like there's all these things. It's very overwhelming to hear and understand. And as a result, once those bacteria are now phages, they're releasing these substances called toxin-like peptides. Now, we've defined these toxin-like peptides too, and these toxin-like peptides can impact all different organ systems in your body. And because you have loss of the good bacteria, you have all of these really bad players being released from these phages in your gut. You have significant leaky gut, significant dysbiosis. Not that we weren't already living in a toxic soup and had a problem, with all this. And then these toxins, a lot of them are neurotoxic. They cross the blood brain barrier and they're just adding more fuel to the fire from just the spike protein alone and causing a lot of issues with neuroinflammation.
Jason Walkup here, founder and co-CEO of mindbodygreen and the host of the mindbodygreen podcast. Please subscribe. You'll never miss a show and you won't regret it. So how do we, because look, the cost of living in 2025, COVID's here and we have to live our lives. And will I get COVID again? Yeah, it's probably likely. I got it in May and I wouldn't have known.
I don't know if you had it in May.
I did. And the reason why I say I did.
Did you test positive?
So the reason why I think I got it in May, I did the labs 30 days later and I went back to my Whoop and Aura data. What I've seen when I've had COVID, my respiratory rate goes through the roof and all my other markers.
But if your nucleocapsid if your nucleocapsid is not positive, you didn't have it.
Well, if it's 30 days had passed, there's the onset.
There's no way it would be negative.
Well, we can offline about that. But at any rate, I am pretty sure I had it given how I felt and my markers, which are always pretty dialed, like my respiratory, everything is very consistent. And they weren't over a 3-day period. And ChatGPT agreed.
You could have had another bad virus, but that's okay. We talked about it all.
Potentially. But the larger point is, look, it's here. People need to live their lives. We don't want to freak people out. So like traditionally, so for most people, the virus will come, then it'll go, your spike proteins will go up, and then they'll eventually clear out. We just have to be mindful about the testing we should do to make sure they're clearing out, because you don't want them lingering and persisting and being a pest, so to speak, in your with the neuroinflammation or your immune system and what have you. So what are the things you've talked about testing and the implications? What are some of the things that are like low lift from a lifestyle perspective to ensure we're giving our body the best shot for clearing out this garbage that we don't want?
So, of course, the first thing are the pillars of health, right? Like making sure that you're sleeping adequately, making sure that you're moving and sweating, getting, like moving your toxins out of your body, supporting your gastrointestinal, your gut microbiome, your GI system, your liver, doing certain things to make sure your body's detoxing properly, and obviously eating, whole foods, like avoiding ultra processed foods, refined sugars, because you want that gut microbiome to be super healthy and you want the intestinal mucosal barrier to be intact, because when you already have a broken gut microbiome, you're a setup for this to begin with. You're a setup for the spike protein to then access the rest of your body systemically and start to replicate, and it's a big problem, so doing those things and obviously enhancing and working on the lifestyle pillars are number one. If we use homeopathy a lot in our practice, so I use a lot of the detox cleanses, like different homeopathic detox cleanses to open up your kidney, liver, and lymphatic pathways, so that you're actually able to move this out properly. But again, if you're not sleeping well, you're not eating well, you're not sweating, you're not respiring, then that's part of the problem too. So you have to be doing all those things. And we have formulated over the last few years from all of the knowledge that our research group has absorbed, and all the 40,000 plus research papers we have in our armamentarium to refer to. We have a very good understanding of the spike protein, of this persistent viral issue, and how to sort of move it out of the body. So we do have, a spike detox and a detox for the gut that we've formulated. It's it's maybe not perfect, but we have testing before and after that show like patients that are worried well or just mildly, symptomatic can with the detox like clear or like significantly lower their spike protein load. And we can actually measure the spike protein through our research laboratories to prove that. So we've been able to show that actually with our research. And we are about to start a big research initiative in the US where we can, validate this, so that's really important. And then we did, because everything's expensive and we're trying to get people to even screen or like understand if they have actually circulating spike protein. We have created there's a website you can go to called ourwellnessjourneyus.com, and you can order the testing there. It's usually through a practitioner, but it will be sent off to the lab that we work with and you can get your results. It's not technically a diagnostic. We can't say it's that, but patients can, you know, sign that they're part of research and they can see that they're making the spike protein from the vaccine or the virus.
Look, it's fascinating, and I think pointing to I think testing is becoming democratized through a lot of different companies right now, and everyone's going gaga for blood testing, and that's good. But I also know our listeners, and more generally, I think the wellness world is really interested in root cause medicine. And so if you're just doing blood testing and getting results, but not really getting to the core of what's going on, it's not really going to take you to the promised land, so to speak. And this is why, in my view and in my experience, COVID in many ways is the root cause of all these things going wrong.
It 100% is, but I think it's also good to know, do I actually have this spike protein? Is it circulate? Is it right? So I think a lot of people want to understand that and know about it. And then if like knowledge is power, right? So then if you're like, wow, I have this issue, let me be proactive and do something about it, Because a lot of people are just like, how do I even know if I have it? And the antibodies don't necessarily tell the whole story. So that's why we're trying to, get this out in some way, shape, or form. We've been studying it for a long time so that people can actually, because when you do ELISA testing, that's antibody testing again. The mass spectrometry can identify through the sequences of the virus if it's viral or if it's vaccine. And it can actually detect, with much more precision and certainty that you have this, that you have this.
Yeah. Look, I think I encourage everyone to do it because I am concerned that a lot of people are just doing the neuroinflammation testing with no context and are maybe freaking out. And it's like, no, actually, well, maybe there's a reason to like be upset. But I think for a lot of people, there's maybe this neuroinflammation that's because of the antibodies, and there's a way out of this, so to speak. Like there is a path forward. It's not as bad as you think.
You know how many people don't feel well? They just don't feel good. They don't feel like the way they used to feel and then everyone's like, well, maybe it's my hormones and maybe maybe. I'm not saying it's not. I'm not saying it's not because you're perimenopausal or menopausal, but then half the time these have been addressed too and they still feel awful. I just want doctors and people out there to start putting it in their differential because when you take a really good history, right? Because I'm a longevity doctor. So I spend a lot of time with my patients. It's not a revolving door of just 15 minutes in and out, you're done. That's why we live in a world we have an epidemic of chronic disease. You have to really understand and like build a timeline with these patients. And you can see for many of them, there is a temporal relationship between when they were exposed to the vaccine or the virus and when they started not to feel well. And when a lot of their biomarkers started to change also pre and post. There are many of them. You can see this. So, you just want to take a good history and it's something that should be part of that differential diagnosis because that's why so many people are flailing and they're just going to this specialist, that specialist, this specialist, because no one's putting it together and being like, oh, it could be this.
And to be fair, it's just so new. I was talking to Frank about this. He's like, this is just so new. This is a new world for us. We're trying to figure this out. We're seeing things we've never seen.
Yes.
And Frank and you're not conspiracy theorists. Like Frank is very like this is real. And look, I think people listen. No, I'm not a conspiracy theorist, and I'm fine. I have no symptoms. Wow, this is interesting. I've got this crazy inflammation here. This makes no sense.
People might be like, well, why does she? I mean, listen, when I left the conventional space, in right in the beginning of COVID, I left my conventional practice, because I was just obviously very burnt out. I went back to IFM, to IFM. I did all my certifications within a year. I was crazy. I had a big why of like being able to help people and connect with people on a much different level than my revolving door of my GI practice of seeing 30 patients a day. Okay. But because I really, when I went into the space, I became a gut microbiome specialist, and and that's a whole other long story of why. And also, I'm a gastroenterologist, but I was doing a lot of blood work on my patients, again, from more the systems biology, angle. And I was doing gut microbiome testing on almost all of my patients. And I was seeing, very like in late 2020, early 2021, the patterns in the blood work changing like I couldn't understand it and it didn't make any sense. So I just started studying this like at the very beginning because my curiosity was so piqued by what was going on. And I'm just a very curious person and I don't take no for an answer and I don't just listen to what everyone tells me what to do. So I just was like, this doesn't make any sense. None of it made sense. And then I just kept pulling back the layer of the onion, pulling it back more and more, and like meeting all these amazing other physicians and scientists in my space. And we just formed this very big collaborative group to really try to understand this. And you're right, it's a beast of a disease. It's a beast of a virus, and the spike protein, what it can do to our bodies is not like anything we've seen with any previous virus ever. And when people compare it to the flu, I laugh. It's laughable, actually. It's actually laughable.
So for someone who's not feeling well and can't put a finger on it, or someone who's like me who feels great, who just wants to know if they've got this thing floating around,
You're like, there's the unwell and the worried well.
I would say I'm not worried. I'm well. I like testing.
So, okay, but it's not maybe what you like to be, but I call it still the worried well because you're curious, you know? So you're like in that category.
And curious, and my view on everything is I'd rather know.
Be proactive.
Yeah, exactly, be proactive. I'd rather know if there's something that I can take care of than wait. So I'm up for it. So what advice do you have for, if people have the ability to see you, obviously that's amazing, but for those who don't, like what are the non-negotiables in terms of the testing they should do or conversations they should be having with their practitioner?
Well, I think it's the sad thing is in the conventional space, until we get the teaching and the education out there to really educate these doctors, it's going to be really hard to find a doctor that can do the correct workup and offer the patients the treatments that they need, unfortunately. So if you can find more of a functionally trained doctor, integrative doctor, you're going to have like better results, especially if you're not feeling well. Like, I'm just being honest. I just feel like if you don't understand systems biology, if you don't have training like that, it's going to be really hard for that doctor to diagnose and treat these patients. So you should try to find a doctor like that that's open to this conversation to begin with and that understands these advanced biomarkers that can even be leveraged through your commercial insurance companies.
Yeah, well, on that note, to rephrase it, like even if you got a doctor who's maybe like a little bit more rigid and not open to some of the new ways of testing, like are there like three biomarkers you'd be like, listen, doc, you just got to do me the solid and order these three labs just so I can get like is it what are those like?
I would order, if they're not feeling good, I might give you a few more than 3, but I would say do the antibody testing, do the spike IgG and the nucleocapsid antibody testing just to see because again, you can use that sort of as a guide based on the patient's history of what's going on, like when they last had a vaccine or a virus, and that can tell a lot of the story if you're still making a ton of antibodies, right? And you shouldn't be. The second thing I would get is a TGF beta 1, transforming growth factor beta 1. I can't believe how high it is. Now, the problem is, I told you the reference range has changed. But if you are walking around the TGF beta 1 above 5,000, 8,000, that is not good. Okay, that is not good. You should not be walking around with a TGF beta 1 that high. The third thing is a D dimer. What's happening is, and we didn't get into this in the conversation, is many of us, even patients that aren't necessarily symptomatic, we're making these microclots. because the spike protein basically infects the endothelium of our blood vessel wall, and it causes a low-grade inflammatory response like an endotheliitis. And as a result, we activate platelets, and then the platelets start to release all these different inflammatory cytokines, okay, mast cells, and even 40% of TGF-beta 1 comes from activated platelets. And then it ignites the clotting cascades, different clotting cascades. But what happens is, because of the way the spike protein behaves in our body, the spike protein's creating these clots that we're not used to seeing. They're more rubbery. We call them like calamari-like clots. That typical fibrinolysis or fibrinolytic pathway that breaks down these clots, it's resistant to that. And so you're making these tiny, tiny clots that are jamming up your capillaries, like your tiny, tiny blood vessels that feed your cells, tissues, and organs. And that's why so many patients have the chronic fatigue, the brain fog.
And how do you test for that? How do you test for the microclots?
That's very hard. You have to go to a practitioner like myself or someone like me that sends it off to this clinic in Alabama, because there's only 3 doctors in the country, or at this point, I think it's only 3 that were trained by this professor, Dr. Isa Pretorius, who's in South Africa, who protocolized this prior to the pandemic. And then they have the fluorescent microscope, which is very expensive, and they've been trained to detect these beta amyloid microclots. That's why they're resistant to the typical breakdown, because
Ah, got it.
they're beta amyloid. And the beta amyloid lights up as green under the microscope. So you can see all this. And so the D dimer, now the D dimer can be elevated or not, but I can't even tell you, like 70% of my patients walking in, even to this day, have an elevated D dimer that aren't coming in for long COVID.
So would it be safe to say before they go there, get the SARS CoV2 spike?
I would, because if I didn't mean to go into micro, but the reason why the D dimer is elevated is because your body's constantly fighting to break down these microclots. Okay.
And is that lab DDMR for people listening?
D-dimer. Yeah. I do it in almost every patient. I screen. So the D dimer, the SARS, the TGF-beta 1, and ANA. I would do an ANA because if the person never had a positive ANA prior, like a lot of people do ANAs, but if you never had a positive and now you're positive, that could be also, especially if your antibodies are high, like causing molecular mimicry, causing something at a cellular level that shouldn't be happening as well. And then the A beta 42/40 ratio, it was opposite in you. In the vast majority of patients, their A beta 42/40s is abnormal. That's the screening I use. And then I check and then I'll go on to check the other markers if that's abnormal.
I feel very blessed that my amyloid numbers or everything's normal except the p-tau, but I'm on this journey and
I will say, I don't mean to, because I just want, so I don't forget, the Quest AD Detect now, it checks both the p-tau 217 with the A beta 42/40. So that could just be one test. It's great, which is nice. So you can have both. Because like in you, right, if I just screen that and you're more of the exception than the rule, I would have missed it, right? But now, because they have both those together, I would have gotten your 217 also and seen that was abnormal.
yes, my TGF, I'm going back to the initial result, was normal, 10,000. He did it at first. TGF-B1 was 10,457. No, it's green, 10,457. That I was normal. And then my SARS,
What do you mean that's not normal? That's what I'm trying to say. 10,000 is very abnormal. It is not normal. They changed the reference range. That is a very abnormal TGF-beta 1.
and then my SARS-CoV-2 IgG was negative.
You mean the nucleocapsid.
Yeah.
So that TGF-beta 1, Jason, is very high. That's a very high TGF-beta 1.
And then but I was negative on the nucleocapsid.
Right, because I think that this could have been smoldering in you for a while. I don't think you had a reason.
To be continued. But that's interesting. Not that I want to be the guinea pig for our audience, but that's interesting.
Right. So now we can maybe do what would be interesting is me, you, and Frank can do some simple interventions, right? Do some stuff to work on reversing and regressing, and we'd see that your TGF beta 1 will go down. We'll see that your p-tau can start to move in the right direction and go towards the within normal limit range, right? Like that could be cool.
It's super cool, and I go back to, like, the why of this podcast and show. If you're interested in getting to, like, the root cause, my view, and I've been obsessing with this over the past, like, 60 days, is there's a lot we don't know, and for many people who feel fine, may have wonky markers, this could be it, and there's something interesting here given, like, this just affected the entire world in a way we've never seen before and are still learning.
Good summary. I like that.
We covered a lot. Is there anything we wanna touch on before we close?
Like I said, I obviously, if I could help the world, I would, there's a bunch of doctors in our network that are they're training with us that, attend a lot of our conferences that can help. I think you have to find again, like a doctor that's open to especially if you are symptomatic, that can help you and help start going down the right path of diagnostics and interventions. But if they go to, so I really like this product, Medicinals 9. That's the compound that we've been giving patients to help them detoxify. It's like the foundational product. It's 9 polyphenolic compounds. We have like the binders, the senolytics, the Medicinals 9, the things that can help the person detox from the spike protein that we actually have proven that we can move the spike protein in the right direction after like 4 weeks, 8 weeks, 12 weeks of therapy. Yeah. And this will, hopefully be published in the near future as well. But you can go to Medicinals, I think it's medicinals.com. I don't remember. But anyway, they can go there and then they can go to our wellnessjourneyus.com if they're interested in doing this like research-based testing to see if they actually have spike protein. My information, they can follow me on Instagram at dr.robinrose, or Facebook is Dr. Robin Rose. And then my clinic is terrainhealth.org. If they want to get more information, about some of these things, they can go to the website. Or if they, I have other doctors that work with me too that are trained in this that can help.
Well, amazing. Such an important topic. We will definitely share with the audience what's going on with me, because I think we can all learn from how I'm approaching this.
Yeah, I think so. I think you're a great test case. I love it.
But, it's such an important subject matter and incredible work. Thank you, Robin.
Thank you. Thanks for having me.